All right. So I guess first of all, welcome everybody to this kind of impromptu StaPH-B call. I know that a lot of people on the call are coming over from the Spheres community, since I know we didn't have a Spheres call this week, and it was broadcast over there. So for those of you who don't know, StaPH-B is a self-aggregated consortium of bioinformaticians at the state public health level, and we have gotten together to kind of solve problems, to kind of come up with a community of scientists who are all working on similar issues and things. And every month we like to have a call to go over kind of issues or problems that are arising in the community and talk about things. It's been a great way to kind of stay in contact with people at the different public health labs, and also it's been a really good resource, I think, in order to kind of stay on top of what's going on just in the community, and we try to kind of keep our finger on the pulse of new things that are exciting and happening. And so we decided that this was probably a new and exciting thing that deserved a call, and so I appreciate everybody for being on, and without further ado, I'm going to go ahead and start sharing my screen. All right. So like I said, I'm just going to go over kind of quickly a little bit about this emerging SARS-CoV-2 variant. I'm going to kind of focus on this VOC 2020-12-01. This is the one that's been identified in England. And so here we go. So the background of this is that the two earliest sample genomes that belong to this B1.1.7, or this variant of concern, were collected back in September on the 20th and 21st in Kent and in Greater London. And as of the 15th of December this month, there were 1623 genomes in this B1.1.7 lineage. And of those, 519 were sampled in Greater London, 555 in Kent, and 545 in other regions of the UK. So there was a large explosion in these kind of original areas where the variant was detected, but then it also spread across the rest of the UK in a rather short time period. And so additionally, it was also identified in 4 other countries. Originally, it was designated this VUI, this variant under investigation, but on further review, it was redesignated as this variant of concern on the 18th of this month. And at present, it's this variant of concern, or the B1.1.7 lineage, is kind of used interchangeably in order to talk about this particular variant. And so just quickly, for those of you who don't know England like me, I had to kind of look at it, where these things were happening. So Kent is in the lower kind of southeast portion of the country. It's close to London, but then by the 15th of this month, it had already spread to Wales and Scotland, which are, kind of disparate and further away. So this rapid rise was of concern. This is a quick little map of, it came from the Penguin website. So Penguin, for those of you who don't know, I think most of you do on this call, is the lineage kind of typing scheme that has been come up with by the Rambeau lab, and it has been kind of very useful in tracking variants and tracking independently arising lineages of the virus over time. And so in the beginning, so this is actually a little bit out of date now. I originally pulled this slide on the 23rd, and this data was from the 12th of December. And so originally there was only sequences from the UK, and we can see that there was this rapid rise. The first sequences were identified back in September, but then the rise we really start seeing happening in kind of November and through December. And the later dates obviously are going to be a little bit more skewed because we don't have the data for those yet. And so looking at this kind of rise in November, it was a little bit alarming. And then as of yesterday, I went back and looked at this again to get kind of an updated map. And so now they actually have a specific page on the Penguin website dedicated to these variants of concern. And so this is pulled from that. And so we can see that, yeah, there's been a rapid increase through December of this particular lineage, and it has rapidly expanded beyond England to and the UK and Australia to these other countries, and as we've seen, and as we will see, even further beyond these as well. And so in the beginning, what was kind of the event that led to the discovery of this B1.1.7 lineage? So there were these clusters that were popping up that were clustering very closely on phylogenetic analysis, and they all kind of shared this set of mutations, these 17 mutations in particular, which are listed here, and it's a little bit hard to see, but I'm going to get into them in a little bit more detail. But one of the main things that really caused concern about this lineage was that, as we can see, so from the beginning of the pandemic, we are averaging a pretty steady rate of divergence from the root, which we are defining as the Wuhan reference strain from the beginning, from March all the way up and through November. But then in kind of the September-November range, we see this jump up and a much higher kind of genetic divergence from the roots in this B1.1.7 lineage, which is cause for concern because there are so many mutations defining this lineage that are stable and that have arisen apparently independently. So this is a bit alarming just in terms of we don't know what kind of effects this is going to have on downstream kind of processes, on vaccine evasion, on infectivity and stuff like that. We've kind of started to find out some of these things, and I'm going to get into that now. But this was just a startling increase in the genetic diversity in this particular lineage, as opposed to kind of what we've typically been seeing. And so these are the particular mutations which define that kind of clade on the phylogenetic tree. And so we can see a good portion of them are in this spike protein. Some of the ones that are kind of most cause of concern, I've kind of highlighted, and I'm going to get into them in a little bit. So there's the 6970 deletion in the spike protein in the amino acids 69 and 67. This N501Y, which seems to be kind of like the defining or one of the defining mutations of this lineage, and it has effects potentially functionally on the spike protein, as well as these other two. And so from the CDC's website, mutation N501Y, so on their kind of blast sort of announcement about this, mutation N501Y is one of 6 key contact residues within the receptor binding domain, and it's been identified to increase the binding affinity to the human ACE2 receptor, which is obviously this molecule entry into the cell. We also have these deletions in the spike protein at 69 and 70, and they've been described in the context of evasion to human immune response, and I'm going to get into that in a little bit. But they've also occurred a number of times, kind of arising independently, which is interesting and potentially cause of concern. This P681H mutation is immediately adjacent to the furin cleavage site, which is another important site for the entry of the virus into the cell. And then this ORF8 stop codon is something that it's not in the spike protein, but it has been kind of loosely associated with some kind of immune responses and evasion in the past. And it also has emerged independently in the past, but then disappeared in Singapore. So I'm getting into some of the predicted functional effects now, just kind of quickly. So there was this paper that was done called Neutralizing Antibodies in Spike-Mediated SARS-CoV-2 Adaptation. And so this was a study of an immunocompromised patient who showed reduced sensitivity to neutralizing antibodies over the course of a chronic SARS-CoV-2 infection. And so during the course of their infection, they took samples and sequenced them from different time points. And what they found was that this N501Y and the spike was transiently detected at day 55. So it wasn't originally detected in this patient, but after 55 days of infection, they did identify that mutation, that particular mutation, as well as a mutation in the RNA-dependent RNA polymerase. They also identified the emergence of this 69 and 70 deletion in the N-terminal domain of the spike protein. And some of the kind of interesting things that came out of this was that then they went and they did some kind of like functional studies into the 16970 deletion and as well as this D796H. And they found that the double mutant conferred decreased sensitivity to convalescent plasma. So that was concerning. So it caused, you know, a reaction to this convalescent plasma while also maintaining infectivity similar to the wild type. And when they looked at the 16970 mutant kind of in isolation, it had about 2-fold higher infectivity compared to wild type. And that was what appeared to reduce or compensate for this other mutation. And so this was still, I have to kind of, you know, say that there are some caveats with these things. These are all, a lot of the information that I'm presenting on are preprints. And so, you know, they haven't been peer reviewed yet. And as is the case with a lot of the SARS-CoV-2 stuff, we're kind of, you know, learning things on the fly and things are kind of happening in real time. So I just wanted to talk about that. But then, so I also wanted to kind of go into this 16970 deletion a little bit more. It has been observed multiple times independently in different populations. So there was the kind of mink samples that made kind of headlines about a month or two ago. This deletion was present in those, but it has also been observed in human samples as well. And so the original paper that I found, which identified this deletion, was kind of what led to this discovery that it caused the S gene to drop out in the TAC-path assay. And so they originally did some sequencing. So this original study found 2 samples where they did whole genome sequencing. They identified this deletion, and they also found that it had this S gene dropout on the TAC-path assay. So then they kind of did a few more samples, 4 which were negative for this S target, 11 which had amplification of the S target, and then they sequenced these, and there was 100% concordance with those profiles. So the ones that were negative for the S target had the deletion, whereas the ones that were present for the S target did not. So then they did a retrospective analysis of these, you know, RT-PCR results, and found that. So I think one of the big things from this too is that they selected CTs of less than 25 for the N target. So of the 3 targets in the TAC-path assay, that's the most sensitive one. And so if we have a better kind of signal from that, then that's kind of indicative that these are true positives. But so what they did eventually determine was that, yeah, this deletion affected either the primer or the probe binding region. And so it was causing that particular gene to drop out in that assay. And so this has been kind of then confirmed, and Public Health England has this is from the some of the work that they have done in regards to this new variant. And so what they found is that this S dropout is a really good kind of proxy for this particular lineage, because when you have the deletion of the 1670, it does cause this S gene to drop out for over 99% of the time. And they've termed this the S gene target failure. So this is of course what we are using now as a way to kind of screen samples in order to determine whether we have this or not. One of the things that I did want to kind of point out, though, was in a lot of the reading that I saw, they were saying that some of these mutations did cause a higher viral kind of load. And so in those kind of cases, we would expect to see hopefully like lower CTs in the samples. I guess it kind of depends on the course of infection and at what time point samples were taken. But so in a lot of the cases, you know, we're seeing really strong signals for these N and the other 2 kind of genes in the TAC-path assay, whereas the S is not present. But so I think in a lot of cases, when people are going back now, we're finding that, you know, the S may not be present in these assays when we've done the TAC-path, but we have really high CT values for the other ones. So that could just be a function of the S being less sensitive than the other 2. And so that it's not, you know, 100% concordance that the S gene means that this deletion is present. Especially, you know, considering certain circumstances, but it does become a good proxy. And so this, I just wanted to show quickly, was like so this is where in the spike protein this deletion occurs. And so it's in this N-terminal domain, which is separate from the receptor binding domain, but it is on this exposed loop. And so this could potentially have kind of immunomodulatory effects or something because of its exposed nature. So I think more studies are really required in order to kind of determine that. And so some of the studies that have been done, so this is from a preprint that did some modeling on the transmissibility and severity of this variant of concern. And they have estimated that it's 56% more transmissible than pre-existing variants of SARS-CoV-2 based on their models. And so it was unclear if this variant resulted in a greater or lesser severity of disease, but from most of the kind of reports that I've been seeing, it does seem to be that there is not a kind of acknowledged effect on the severity of illness. It's just more that it's a transmissibility increase. And so in that particular paper, they recommended a national lockdown with closure of primary, secondary, and universities in order to reduce this reproduction number to less than 1, because they're seeing a greater than 1 reproduction number in their kind of models as of right now. One good bit of news, though, that I wanted to point out is that the BioNTech CEO, the chief executive, does say that his vaccine is highly likely to work against this UK variant. So this is hopefully true, but I think it's still a little bit early to say with kind of certainty whether this is going to be true or not. But the fact that the vaccine does affect a certain portion of the spike protein and is not expected to have any sort of kind of decreased efficacy is good news. And so now I wanted to go on to the North American detection, because that's where obviously we are mostly living, probably. So as of when I started this slide presentation yesterday, the only kind of North American detection that had happened were these 4 cases in Canada. So they were found in British Columbia, Ottawa, and the Durham region of Ontario, but they were all connected to travelers from Britain. So this was kind of something that had been seen in most of the cases that were announced kind of globally, was that they had traveled to Britain, and so there was kind of this connection. Cases were travel associated with the UK, which is good news in a certain sense. But as of yesterday night, the first case of this variant was detected in Colorado, and as of right now, from what I can tell, maybe the people in Colorado have different information, but that case did not have connection to UK travel or somebody who had traveled to the UK. So that is a bit concerning, because it could potentially now mean that this is community spread. And so now I wanted to get into a little bit of the US surveillance efforts. So from the CDC kind of announcement, we've sequenced 51,000 of 17 million positive cases. So just as a, back of the napkin calculation, that's about 0.3%. So we don't have a huge number of sequenced cases to the relative positive cases. So then in terms of surveillance efforts, this does kind of hamper our knowledge of what's going on with the virus and our ability to kind of respond to it. This is ramping up to hopefully over 2,700 sequences a week. I know that the CDC is going to be coming out with some announcements related to this soon. So stay tuned on that. And I know that there is the, I think it's the N3 effort that's going on right now, where, where CDC is soliciting isolates from the states to be sequenced by them. As of right now, there is a screening travel kind of for COVID cases, for anybody who's come from the UK, and the effective date was 2 days ago on the 28th. So air passengers arriving from the UK were required to test negative via PCR or antigen no more than 72 hours before departure from the UK. So I think that this is still useful and probably will be something that we want to work with our health departments and things on, is travel to the UK. But then I think, as is the case here, we've increased prioritization of these S dropouts for sequencing. So, everybody who's doing the TAC-BATH assay, I think we were really fortunate in that particular analyte drops out when we have this particular deletion, which is a good proxy for this. And so, we were kind of lucky in that case in that we have a way to kind of preemptively screen for it and hopefully identify cases. And so then I kind of wanted to go on to this now. So this is not really related to the variant so much, but I just wanted to point out that, we do see kind of rises and falls of different lineages kind of throughout time in the US. And so I think it is worthwhile to kind of keep track of these things and maybe have a way of, identifying when a particular lineage is kind of expanding rapidly or not, because that's kind of what led to the identification of this particular variant of concern. And so next strain is really useful for this. And so with that, I wanted to thank Public Health England, Spheres, COG, Next Strain, Penguin, all these people who've done all this work. This is where I got most of my information, and I think that they've been doing an amazing job in order to get this information out, which is really useful for all of us. And now I kind of wanted to go into maybe a little bit of a discussion. I didn't want to be talking for this whole point. I kind of wanted to maybe, throw some discussion points out for people, and then also get, people's kind of reactions. How are you prioritizing your samples for sequencing? What's your plan of action if you identify this notorious VOC? And, if sequencing fails for the variants of concern, how are we going to go about doing this? So I'm going to kind of open this up now to the floor, hopefully, and anybody who has anything to say, go for it.
Thank you so much, Logan, for the brief summary of the whole UK variant. Do we have Colorado folks on the phone that or on the call that can give more specific details in terms of like the specimens, the CT values, the sequencing part of the story?
Laura, Molly, you still on?
Yeah, so this is Molly. I think of anyone, Laura was the one who was working with Shannon to assemble the genome, so she has a bit more knowledge than I do. So I'm going to hand it over to Laura if she's still on the call.
Yeah, I am. I don't remember what the CT value was, but Shannon did the initial assembly early yesterday morning just using Arctic's pipeline. And then after that,
Hi, Laura. I'm so sorry to interrupt. I'm having some trouble hearing you.
Oh, can anybody hear me?
Yes,
very quiet.
Oh, okay. Can you hear me now?
Yep, 5 by 5.
Okay. Yeah, so Shannon used the Arctic pipeline to do an initial genome assembly and noticed these B1.1.7 spike mutations. And so after that, I ran just a more stringent SNP filtering pipeline just using IVAR, just to make sure that we were super confident that these were real. And so these SNPs in Spike all have more than 20x coverage and mapping quality is over 30. So we're fairly confident that these are real. And the genome itself has over 99% coverage and sequencing depth over 300. So it's, we think, a very nice genome. So yeah.
So it showed almost all the mutations that are listed.
Yeah, so all, it has all 8 of the spike mutations are there.
And Laura, do you happen to have the CT scheme information?
No, I don't. And I'm not sure Shannon's on.
Okay. And how about the epidemiological background of this particular positive patient? I know, like on the public announcement, the only things mentioned is he has no recent travel whatsoever.
Yeah, so he's a male in his 20s. He doesn't. We don't have any obvious links to travel or someone that had traveled. Our governor's press conference today stated that he is a National Guard member who had been working in a long-term care facility since about the 23rd. But they haven't found the variant in any of the long-term care patients yet.
And have you guys identified any potential exposure source?
We don't know yet, no.
Okay. Interesting.
So what about any other ORF8 stop mutation that Logan pointed out as critical? Did you have a chance to look at those or not yet?
Sorry, what was the question?
You said all the 8 spike mutations are there, but what about the other ORF8 stop mutation that Logan mentioned as a key one, and anything in the ORF1AB and N? Do they also exist in that variant?
I'd have to double check about the ORF.
Oh, okay. Yeah. Okay. Thank you.
There's a question about a collection date in the chat. It was collected on Christmas Eve, 24th. And his symptoms were mild.
Oh.
It's another one of the questions in the chat.
And so is it true that the initial kind of contact tracing showed that there wasn't any sort of travel or associated travel to the UK?
Correct. Yeah, that we've been able to figure out so far, but that's ongoing.
That is concerning.
Well, I don't want like bring the whole conversation as a grill to Laura in terms of the specific to this case. I think if I remember this correctly, the only one question that is unanswered is the CT value scheme, which we're waiting for Shannon to log on. Is there any other questions in terms of the Colorado case? And I think you guys spotted another one, right?
Yeah, we have another putative one that we're still looking into.
And no epi link between those two cases.
I'm not sure.
Okay. Any other questions from the audience?
I have a question. So for everybody that's working in public health labs right now, how many of you are actively going through all your PCR results looking for the S dropout signature?
So I know in Virginia, we are doing that right now. And so we're not looking at all the S dropouts. We're just looking at the dropouts that happen between this kind of like, I believe it's early November to December 1st, because those are the most likely samples that we have still retained. And what we're finding in a lot of those cases is that we have really high CT values for those. And so on initial sequencing, it doesn't look like a lot of them passed our kind of, internal quality filters, just because we weren't able to get, full coverage of the genome. And so that is going to be something that we have to kind of, I think, delve into a little bit and see if we can get, at least coverage of the spike gene or some of these other genes, and see if we have those variants in there. But that is going to be, I think, a cause for concern for us. I think, yeah, in a lot of cases, we are probably going to see those as dropouts just being due to the fact that there are higher CT values for the other two targets anyways. And so since the S is a little bit less sensitive, it just didn't amplify.
So in Utah, we've requested all of our major lab partners here that are also doing testing with TACPath to send in their S dropouts as well as inconclusives, just because if the S gene drops out, and then for whatever reason, they don't amplify one of the other two tests. And we're going to sequence all of those. We did one small subset from a local partner here. We had 18 samples. CT values ranged from low 20s to mid 30s on those. All of them had no S gene amplification. 15 of those 18 passed quality control. All of those 15 had the deletion at 6970, but no other mutations associated with the UK lineage. We've seen a couple of those mutations, those deletions as well in Utah before this, going back to, I think, May. So we weren't too shocked by that, but it looks like you might catch more of just the deletion that affects the binding in S than you will of the actual UK variant or the UK lineage. So we'll see as we get more stuff on the sequencer what things look like. But yeah, that's kind of what we've seen so far in Utah. And we're planning on just sequencing as much as we possibly can, focusing on those S dropouts and inconclusives with one set of sequencers, and then we'll also keep moving forward with our sequencing of positives in near real time as well with the other set of sequencers.
Well, we're doing something similar in Michigan as well. We do not have that many actually S dropouts that we're chasing down internally, but instead of that, we do have a couple commercial labs that have used TAC-PATH, and we actually had a bunch of their samples in-house that they informed us relatively recently that a lot of those were actually S dropouts. They were positive, but S dropouts. So we're going to try and push all of those through as well in next week. And then we're also reaching out to a bunch of commercial and clinical labs across the state, trying to increase our surveillance in general and using this to support the need for sequencing surveillance within the state.
Before the updates of Minnesota, I saw Shannon logged on. Hi, Shannon. Thank you for take the time to the call. I think the Laura and Molly answered most of the questions, and I think the only questions in terms of the Colorado B1.1.7 variant specific question would be the CT combination of those specimens.
Right. So the CT value of the CT values of the one that we can or believe we confirmed, they were both 12 to 13 CT for the N gene and the ORF1AB. The one that we are considering probable, where we got good coverage on most of the mutations except for the 501Y, where we don't have any data at that region. That one, the CT value is around 20, it's 24.7 for both the N gene and ORF1AB. Absolutely nothing detected for the S gene on either one of them, nothing above background. So that's pretty much what we were looking at.
So it's a pretty hot specimens.
They were.
Oh. All right.
Yeah, I mean, we have a list of something like 1,400 from December and through November of S gene negative, but those are mainly in the 32 CT range. So obviously low viral load. It looks like the S gene drops out first, and that's a tough range.
So that makes me curious about the whole, I mean, UK have, this surge of the variant, and what's their most common sort of like CT value combination? Are all the cases have like a relatively low CT value while the S gene dropped out? Or some cases shows, N gene or ORF1AB with like mid 30s or early 30s. Duncan
Oh, sorry.
Or,
I did have a question too, and I believe, I forget if it was a UK press release where one group's data showed the proportion of S gene dropouts in their total sequence or their diagnostic testing in their lab from the beginning of COVID on. And the proportion was very low, below 10% for most of the length of the pandemic. And then beginning of December, it just started to jump up to 70%. So that I think was a very strong indicator. and also sobering.
So yeah, I think so. There's at least one other state that I'm aware of right now that has at least what they believe to be a confirmed report. And in many cases, I think in places where groups are finding it, it tends to be in fairly recent sets of samples. What is a little bit troubling is that many of these don't necessarily have travel history, as Logan pointed out. And in many cases, they're in suburban or exurban areas, suggesting that they're not necessarily directly travel associated. There's some degree of community spread. So, you know, I think that is something that's interesting. One thing I did want to mention is, you know, I think this has helped to underscore the value of sequencing in a lot of state and local jurisdictions. It certainly has at least renewed interest and underscored the importance of gathering these data. We did put in place a number of not only the national sequencing SARS-CoV sequence-based surveillance NS3 that is spinning up and should be starting to gather viruses from across the country, but we have a number of contract mechanisms that we actually have put in place over the past week. These had actually been planned for a while, but suddenly they got supercharged over the holidays, and we were able to get them out the door fairly quickly. One of them is a contract with Illumina and Helix Diagnostics, and Helix provides on-site or testing for San Diego County, but they also offer home testing kits across all 50 states. And one of the advantages of that is it has broad geographic reach, and they run TACPath on all of these, so about 30,000 TACPath assays a day. What they are doing in the first set of samples that are being sequenced is essentially prioritizing samples that have S dropout. So basically an absent S signal and CT values of 25 or lower on the ORF1AB and targets, and basically enriched a sample set for that. So we should have data across multiple states for suspect, high probability or high possibility, I'll call them that, specimens sometime today. So we should have more data on essentially the extent of spread. You know, I think a lot of indicators are here. I think for one thing, there's been a number of labs that have been looking pretty intensely in places where we should find this variant, places that are associated with travel, places where you typically expect to at least have a hit. And, you know, we went through several days without finding any. You know, we found other 69, 70 deletions, other reasons for why they might not necessarily meet that. But, you know, it took a while to actually track one down. So it's tough to pin this one down. The places where it should be, we weren't seeing it, or you didn't have any early representation. And we've been finding it in some surprising places to date. But hopefully we'll have a better handle on when and where.
Hey, Duncan, I had a question regarding with the US cases, and there seems to be a lot of assumption that, you know, it's UK derived. Is there any conversation of, like, you know, given how many cases there already are around the world of just cases of convergent evolution, where this is just arising actually from the US population as well, independently of a UK transmission, or is this the perspective we have right now, where it's internationally transmissible?
I think in this particular virus, it's unusual, as Logan showed. You know, it's unusual in that there's a whole cluster of mutations that basically popped up virtually out of nowhere. You know, there isn't necessarily a lot of precedent for it in if you go through the global phylogenetics. So one of the reigning theories out of the UK is that it basically took root in an immunocompromised individual and just sort of sat there accumulating mutations for a while, and then you had late stage transmission. I mean, that's probably a reasonable assessment. I mean, I've seen a few other theories floated, but you know, reason for it to basically pop up, it's definitely curious. And as such, you know, it is characteristic enough that you can identify it. You know, the likelihood of all those different mutations occurring simultaneously and convergently seems pretty low. That said, you know, there's a number of viruses around the world that have convergently evolved some of the same mutations. Like N501Y has a popped up a few different places. There's a separate variant out of first identified in South Africa that we've seen in a few other places. So, you know, there are some, there definitely some, it shares mutations with the others that have popped up, but I think this variant is characteristic in the fact that there's a lot of them together. It has a very, very distinctive signature.
I think one comment to make is just that I think it's important to avoid, I don't want to minimize the importance of the UK lineage, but I think it's important to avoid groupthink here. The issue is not the UK lineage. The issue is the length of the coalescent tree. That is, the issue is the amount of circulating virus that's out there. The entire, you know, the mutational space is being sampled over and over again. And so, the reason, you know, it may have appeared first in the UK, but you know, N501Y may not be the most problematic variant, or the set of variants in B1.1.7 may not be the most problematic combination. And we have to be aware that the UK is where the light is. And so that's where we have the best data from independent locations by region about transmissibility. That's where the data is, but that's not necessarily, we need to avoid over focusing. I mean, we need to not minimize the importance of this because something with this profile is extremely concerning. At the same time, we need to recognize that there are other variants in spike and that there is ample opportunity for the possibility and in all, you know, the probability that these issues will arise independently, and we're, you know, likely to be dealing with more transmissible COVID going forward. And so I think it's critical, obviously intellectually, that we remain with open minds, but also that we not tailor too much of our strategy toward S69, 70 deletion variants and S gene target failures.
So Jacob, I think you bring a good point in terms of, you know, moving forward. I mean, there is now, it's more than the B1.1.7 variant. You also have the South Africa variant as well. I guess my question is, what is the root cause of this, you know, suddenly fast evolving viruses? I mean, one slide in Logan's presentation is you saw this like suddenly jump of this mutation process. I read it somewhere, I think it's on Twitter, nowadays everything is on Twitter, that it might come from like a immune compromised persistent infection patient. Do we have any evidence of those? Like, I think if we figure out what causes this, you know, accumulation of deletions/mutations, we might, you know, bring our molecular surveillance one step earlier.
Sean, unfortunately, I think what Jacob said earlier is the cause of this. It's the total branch length of the coalescent tree has just gotten too damn big, right? Like the number of viruses circulating on the planet for the multiplied by the period of time that those lineages have existed, you just have a ton of space to explore. And so it was just a matter of time before this kind of thing happened anyway, you know?
Well, Danny, I mean, yes, I partially agree, but I think I actually throw out this question during the virtual AMD today to Trevor Bedford. You know, with the amount of virus burden worldwide, are we going to see tons of, you know, unique increased pathogenicities variant? And I remember clearly his answer is because the sort of like homogenize of the human population, you know, he worries more about the human give it to mink, mink give back to human scenario rather than the transmission among human beings. But apparently this is not the whole picture, right? Now we have seen the surge of the UK variant and South Africa variant. And I guess, you know, explore or to the root of the cause would definitely be important.
I think my own take on this is that, you know, it's interesting because at the end of the day, the causes, the solutions are all the same either way, right? There are a lot of the same types of interventions that you would do at the public health level. I think for me, you know, as concerning as the current situation is, I kind of hope that it's a I don't know, like a crisis we can take advantage of in a way. It's a kick in the pants in the US at least, in terms of realizing where we need to be in terms of genomic surveillance in general. And I've always felt that, you know, the search for the UK lineage in the United States will be relatively, you know, brief. I mean, Colorado's found it already, but at some point it will be everywhere. And what you want to do in terms of taking advantage of this opportunity is setting up an operation where you're able to keep searching for all the other lineages, right? That may be of concern, vaccine escapes, and you know, things that wouldn't be, and that's why you kind of don't want to overfit the process too much to just the UK lineage, right? It'll be easy to find because it's so distinct looking. You're not worried about being just, did you get those 2 SNPs right? There's a zillion of them. But yeah.
Yeah, and of course,
That's
moving
a
forward,
similar
there's
approach.
Sorry, go
I
ahead.
was going to say that's a similar approach to how we're taking it too, in that we're concerned about the variant and that we're going to surveillance for it and keep an eye on it. But it was honestly only a matter of time before we saw something like this occur. And when's the next one going to occur? And if we over focus on this single variant, what's the chances that we miss something in the other surveillance and that we now leave gaping holes in our surveillance because we hyper focused on one area or one thing? So we're really using this as kind of our driving factor that, hey, this is what we've been doing. Look what we've been able to do. Look what we have been able to do. Now look, this variant has kind of shown that we have holes in our process, and help us fix them. Help us, give us support that we need. Here's what we need from different partners. Here's how we can keep this evolving and moving forward. And it's going to be a process as we go forward. But even with any of the variants that occur, like the UK variant or any of them, it's not going to change the general public view. It's not going to change what we tell people of masking up, so social distance, at least not right now until we have more research on what's going on. But I think we do need to be aware of other things that may be occurring, other variants that may arise, and not get hyper-focused just on one area.
Yeah, I agree, Heather. I mean, I think, you know, this variant got so much publicity is due to the, you know, aggressive approach that UK government was doing. And I mean, at least in Minnesota, we're taking the similar approach, you know, going back to of all of our old TechPath results and reaching out to clinical partners to do a thorough search in terms of this unique CT combination and sequence anything that showed up. Another elephant in the room I want to bring up is, do we have a strategy, or each state have their own strategy to do the molecular surveillance after, you know, the massive vaccination took place? Or do we have any national strategies from CDC?
So I can talk a little bit about national strategy.
Wonderful.
Yeah. Well, I mean, to be honest, there were plans in place to roll out large-scale national surveillance starting essentially last summer. And someday, perhaps over many, many drinks, we will go over why it's taken a little bit of time to get that up and running. Bottom line, though, is that it is a hybrid strategy that we're rolling out. And right now, we don't have good visibility in large parts of the country. And I think we've been pretty honest about that. You know, I think what Spheres, for example, was an initial effort. Our goal there was to start building the community around sequencing efforts, to start standardizing data and metadata, and to use it to get an early look at what was circulating in the country, and to bootstrap a national surveillance effort. But I think what we expected was that the national surveillance effort would follow by a couple months, not, you know, many, many months. And that we could then use that network to essentially start investigating things of interest or things that happened in and around surveillance. In terms of broad scale surveillance, we're rolling out a hybrid approach, as I mentioned. So we've got a number of commercial clinical labs that will be providing sequence data directly. This is a little bit of a new model, but we realize that access to samples is something that continues to be a challenge, and ensuring that we have timely access to a lot of data seemed to be the right approach. We're supplementing that with, as I said, what we're calling NS3, the National SARS-CoV-2 Sequence Surveillance Platform, which essentially is based on seasonal flu surveillance. It has a regular set of specimens being captured at all ELC jurisdictions and basically sent to CDC so that they're all biobanked in one place, that they're all run on one sequencing and bioinformatic pipeline. And that the viruses can be selected and pulled out for additional characterization as needed. So that, that's sort of a hybrid approach to at least look at overall, 10,000 foot view of what is circulating in the country, what is circulating within regions, and, how does specific vaccine pressure impact that? We're also starting to roll out a series of different, we have broad agency announcements out. We have a few other strategies that are specifically going to be looking at vaccine efficacy, vaccine failures, and essentially doing a whole of U.S. government risk assessment around the viruses as it rolls along. But first step was really starting to get much more comprehensive data, because it is. Yeah, it has been a challenge for us. It's been limiting to not necessarily have consistent baseline. And I know that many states, even in places where there is very robust sequencing, once you get outside the jurisdiction, it's there be dragons. There's really not a lot of data on what's circulating more broadly, or how to put some of the things that you're seeing at a state or local level into context. And as vaccines roll out, that's going to become increasingly important. I think in some ways I don't expect us to chase every single variant of under investigation. That's a lot of white rabbits, and I think, but I do think that this one is unusual enough to at least merit our attention, and it's certainly concerning enough to merit our attention. But it also serves as a fire drill for, as vaccines roll out, if we have certain emergence of vaccine escape or breakthrough, we want to be able to identify those quickly. And this, at the very least, has shone a cold, harsh light on the fact that we've got some major holes and have been struggling to fill them. So hopefully that will help at a national level. This is completely separate from anything that's happening at state level and anything that we can coordinate through spheres and those sorts of things. Those are all different tools that I think we're going to help adjust as this rolls along.
Mm-hmm.
And can I just wanted to add, this is Jeremy Lubin, that we also, we need a way to follow up on the sequences to look at function, to see if sera from people, plasma from people who've been immunized is still working. And that's a kind of tricky pipeline. It's all been really ad hoc so far. I know, for example, the people at Moderna are waiting for G blocks to arrive to clone the variant to see if the samples they have are still neutralizing. But I think there also has to be a back end, pretty fast kind of path that people agree is satisfactory, if possible, to follow up on that. Because the fact is, as far as I know, we don't have any information yet about vaccine efficacy across this variant and or any of the others. There are plenty of other, as people have mentioned, plenty of other variants out there that are curious with large deletions and unknown effects on neutralization.
This is Tom Friedrich from Madison. I just want to second that point. I think it's really important that labs will very quickly get swamped trying to phenotypically characterize viruses of concern that may have concerning, molecular and or epidemiological signals. I was on a call with WHO yesterday where folks from Public Health England were talking about the fact that they've actually had 4 variants of concern that they've sort of gone one to the other, trying to grow stocks to share with the international community for just this kind of virological characterization. And they're still in the process of making stocks of the B1.1.7 variant to share internationally. So we really need to have local capacity to be able to characterize viruses once in the places where they're detected. And you know, no one lab, no one reference lab is going to be able to handle that.
That also could be done kind of in stages. That is, you know, pseudotypes have been very informative, and so far I see no reason why the data from pseudotype assays is not accurate reflection of the full virus. So those are much faster, and there are lots of labs that are set up to do that. So all of that work could be divided up in a network quite readily. I don't know. That's something maybe those of us who do this kind of work should discuss.
Totally agree.
This is Ryan from NCBI. I was just curious, is with all the sort of resequencing and everything going on, is there any effort to sort of catalog other variants that are associated with the S dropouts that aren't the UK strain? Since that seems like a convenient way to identify things that could be problematic.
Just as an aside, I know that it is 3 o'clock, so I just wanted to let everybody know. I don't want to take up any more of your time, but yes, I think that this is an important question, and I would love to continue on. I can stay on. I don't know if any of the other moderators, Sean, are you able to continue the conversation for a little while? Okay. But yeah, I don't know of a way to catalog the variants under investigation that are not these UK isolates yet.
I mean, I think Ryan's question was specifically about the S dropouts, which I think are always going to have a deletion at 69 or 70. I mean, we've seen S dropouts that have deletion just at 69. I think once people start depositing all the data and we're just able to look kind of more at the whole big picture, it'll become a little bit more obvious.
Yeah, that was what I was asking. Thank you.
I think these are really highlighting key issues, and I think it's really just a question of, like, you know, where's the puck going to be next? Like, we understand now the issue is just data, and what Duncan is saying is that there's going to be a lot more data coming. But then when the data comes, who's going to look at it dispassionately and say, you know, these are the variants of concern based on, you know, what we know about epidemiology and biochemistry and virology? Are we going to rely on the wisdom of the crowd? Because that's a bit dangerous to do. I mean, are we going to rely on Emma to give us a tutorial on the variants, or do we have? I mean, because that worked great, but you know, is there a system set up in place to integrate the information, prioritize the variants, and then getting back to what Jeremy and Tom said, then, you know, based on what we know, biochemistry, epidemiology, virology, can we work, you know, can we clone these things? Can we put them in pseudotype virus and then go all the way to, you know, to live virus? I think that's where the puck is going to be, you know, sooner rather than later.
So Jacob, to answer your question, you know, I think it's a combination. I think we are putting together an all of USG approach to look at that. So, you know, BARDA, CDC, NIAID, NCBI, a whole bunch of other entities, FDA, obviously. And I think that will be an important source of risk assessment. But I think, you know, we're also open to, I think the plan in doing that is also to have a team of expertise from across academia, across the broader U.S. sector, just to be able to point out things that may be in our blind spot, because I think we realize that there's not all that expertise exists in government, and we need to be sure that we are looking at this from all angles.
So then, is this something that maybe the kind of more local and state levels should be trying to pursue? Is like just finding partners within our areas that we could then kind of form these coalitions and start doing this kind of testing? Or should we kind of maybe have a more national approach strategy?
It would seem to me that the functional and biochemical should be a national kind of thing. I don't think every municipality should be worrying about that, but each municipality has to worry about what's in its backyard,
I think,
and get that information out ASAP.
I think that's a good way to do it, is have kind of column A, column B, because this is such a vast amount of data to work with. It might be easier to identify variants quicker if we have little subgroups, or if we do it by region or state and then compare nationally.
So this is Ryan again. From not a public health background, I'm curious. Obviously, you want the sort of in vivo, in vitro like assays to confirm. That's like the best confirmation if a particular mutant or strain or whatever has an impact on vaccine efficacy or whatever. But is that, from a public health lab perspective, do you need that confirmation before you want to be notified to take some sort of additional preventive measures, or is something further upstream sufficient, like for you to want to be notified and perhaps take some measures?
Aren't the public health measures going to be the same? Whatever.
I mean, maybe. I don't know what else would be. I don't know what else would be done.
I mean, my sense is that the public health measures have to be in place, and the recommendations there are not really going to change, other than maybe people shouldn't be flying or something like that without getting tested first. But I think the really critical questions are whether any of the therapeutics or vaccines or interventions are going to be disrupted. And those are things that need to be acted upon in some real concrete way. So for example, an RNA vaccine, the sequence could be changed if needed. That can be done rapidly, assuming the regulation of that is not too dense. And that kind of thing in theory could be done immediately once there was enough concern raised from say a neutralization assay, or I mean, I guess from the public health standpoint, if you see a variant soaring the way the UK, so-called UK isolate has done, that would be another alarm, and that might come before the biochemical or functional assessment has occurred. I think either of those things have to be on the radar for everyone.
This is Adam Loring. I agree with you, Jeremy, but I also want to add, it is important for non-pharmaceutical interventions as well. Right?
Really can't hear you though. Can you try and speak up?
If the R0 is higher with this variant, then it does inform non-pharmaceutical interventions as well. It's not just about the therapeutics and vaccines, because if you need to impose more stringent, measures, in terms of masking or reduced size gatherings or this, it's going to be that much harder to get that variant under control. So I agree with you, but I also extend it.
I think that's an important point, Adam, especially because this narrative that's emerging now that the virus is less transmissible among children, that's going to lead to, rationales for schools reopening, which we should do if we can do it safely, but that may change if variants emerge that are more transmissible among children. So
I want to second that point. I mean, I think people are looking to us for guidance on what the meaning of this new variant is. And I think that trade-off is really critical to emphasize, that R0 is higher. And so if we don't change practices, if we don't intensify the public health measures, transmission is going to get worse. That's simply the trade-off. And so there may be nothing we can do, but that implies that we suffer the consequences. And in fact, there are things we can do, like increasing our vigilance around masking, around distancing, around gathering size. And I do think we need to be making those points.
So if it's helpful, CDC just released a bunch of information. So we've updated a lot of pages and actually have a public page that's designed for not only technical experts, but also the general public on some of these emerging variants. We're planning to update that as we go along, but we felt that the science briefs were something that were CDC had not necessarily had as vocal a voice as we should have in that. So that's something that we are working to address. We also have some talking points that I think have gone around to most state public health departments now, just to help in some of these discussions, since we realize a lot of groups are getting questions right now.
Related to our earlier, sorry, this is Ryan again. Related to our earlier point about who's going to be looking at all the data holistically, is there any effort to ramp up sequence submissions in light of the new, like the looking for the UK variant in the US, or are people as ramped up as they can be?
I can say in Oregon, we are definitely ramping up. I just onboarded someone yesterday. We were ramping up before this to try and catch more of the wave. So we're trying to get to now 2 sequencing runs a week on the order of 200 to 500 samples, kind of depending on what we have ready to go and how the staffing is able to incorporate that. So at least on our end, we're trying to ramp.
I'll just note that I don't necessarily work with the submissions team at NCBI, but I know I know GISAID submissions is still simpler than GenBank submissions. So if you're still encountering roadblocks, we'd still like to continue to hear that to help us prioritize where to try and improve things first.
I think one of the strengths in the UK, in addition to the fact that they're sequencing more, is that there is kind of a central committee of sorts, de facto, of experts who are pretty rapidly putting out assessments of what they're finding. And I don't know, I don't think we have such a thing in the country. It would be nice to have such a thing, maybe centrally, that's looking over the whole country in the same way that they're doing that. I don't know, it's much more complicated, I guess, with the CDC and all of those individual states and all of that. But I don't know, Duncan, maybe.
No, yeah, I agree with you completely. And in an ideal world, we would love to have that. I mean, the challenge that we've had is that, sequencing has been pretty patchy. So it's difficult for us to make broad assessments about and interpretations beyond, some specific regions of the country. So it's, I think it has been challenging. I think that is something that we're shooting for. And as we get more comprehensive data, I think that will definitely help us make some actual assessments and have those kinds of discussions. I think our goal in setting up some expert committees is going to actually be to review the data as it comes in. But first thing is getting consistent national picture of what's out there, what's circulating, what's important, and having that baseline data be pretty stable so that we can actually look at trends over time and those sorts of things. Because if we're just getting intermittent sampling from various corners of the country and sequencing that really is just passive, it's difficult to make a lot of these long-term assessments of the importance of what you're finding. You're just getting little tiny pieces of the elephant rather than a view of the whole.
Is there a sense that there will be more central push for this kind of thing going forward?
I think there will be. And, one of the challenges has been, to be completely frank, has been funding and the ability to actually drive that forward. You know, doing sequencing at that scale is not inexpensive. You know, countries like the UK obviously have a number of structural advantages that we don't have. You know, they have you know, national healthcare, and you know, the fact that they already had a system that allowed them to, you know, their data analysis, for example, is all centralized as well. They're able to run it through Climb, and essentially all of the data metadata management is happening through, you know, it was an absolutely heroic effort to put that together, but what it allows them to do is channel the sequencing efforts of all these different teams through a common portal, have common data management, and be able to look at things fairly regularly. You know, for a variety of reasons, jurisdictional reasons, data sharing reasons, that's more complicated here. But I don't think it's out of reach. And I think, you know, the first step in fixing a lot of these issues has been just gathering better and more representative data. From there, you know, I think everything else will be much more meaningful, including a lot of the state investigations, cluster investigations. Once you actually have a sense of what is the background, why is what you're looking at unusual or not, rather than just having to speculate about what's happening outside your jurisdiction or outside the scope of your lens, you know, I think we can say a lot more, and we can say it with much more certainty.
Well, it's 3:15 Eastern time, and I want to wrap this up, and many of you probably have another meeting to jump on, and I want to thank everyone to call in today, and it's a very nice, organized, well-discussed call, and thank you, Logan, for the comprehensive review of the B1.1.7 variant. And you know, if time permits, we will do this again with new development happen. So thank you, everyone, and happy holidays. Happy New Year.
Thanks again, Logan.
Thanks all.
Thanks, everyone. This was a great conversation.